audience. It's really great to be with you virtually tonight. Hopefully one time in the near future, I'll be back in your country and get to experience all of the culture and the people and the procedures that I took in the last time I was there in Bogota and in Cali. So really great to be with you this evening. Tonight I've been tasked to talk about hemodynamics and durability, but as was mentioned, I'm kind of proficient in the technical ability to implant this particular valve, the Evolute, as well as all transcatheter heart valves that we now use this cusp overlap technique for. And you can see here just kind of some musings that I was doing, in my kitchen back in 2014 when the cusp overlap technique was kind of being devised, and just trying to think about this whole concept of parallax to understand exactly what we're seeing fluoroscopically and how that would relate to device implantation, especially with the Evolute platform. And so tonight I'm going to talk more about hemodynamics and durability and some exciting new data that we have from the ACC Congress that happened this past year. So this valve really has been fashioned on a background of hemodynamics, and really that's what this valve has been about since its inception. The supraannular platform is supposed to render first-class hemodynamics. And, we've got inklings of what the importance of this would have been, even back in 2018 when Howie Herman published the seminal analysis from the TVT registry showing that patient prosthesis mismatch with TAVI valves does matter. And it matters in a degree that I don't think many of us would have anticipated, where if you have severe patient prosthesis mismatch, your mortality is increased, but not in a longitudinal fashion, in an immediate fashion. And if you see this graph, it just goes out to 12 months after the procedure. And if you have severe patient prosthesis mismatch, these lines separate quite a bit. And for people that are unfamiliar with this term, it's an indexed effective orifice area across the aortic valve. And so if that is less than 0.65 centimeters squared per meter squared, you have severe patient prosthesis mismatch. So why would that happen? Why would severe patient prosthesis mismatch happen with TAVI valves? Well, in this very nice plot, you can see with the force plot, you can see that basically it's going to be valve-in-valve procedures, valve sizes of less than or equal to 23 as being the biggest predictors of whether someone would develop severe patient prosthesis mismatch. Now, valve size less than or equal to 23, if you can think about the TVT registry and where things were in 2018, most of the commercial valves that have been implanted at that point in the TVT registry were 23 millimeter Sapien XT valves for the 23 millimeter size. And so that's kind of what was driving some of the odds ratios in this forest plot that you see here, and obviously quite significantly. So then Rebecca Hahn came out with this paper around the time of TVT, was the talk of TVT in 2018. I was there to see all of the various things that kind of came out of conversations about this paper, but basically these are a bunch of partner authors, Edwards authors, as well as some core valve US pivotal TAVI authors coming together as core echo labs and looking at hemodynamics in quintiles across the board. And here we have area going from a low quintile starting at 248 millimeters squared to a high quintile of 678 millimeters squared, showing you a Doppler velocity index or a dimensionless index of less than 0.5 across the board. And this is not good. Having these types of hemodynamics in a surgical population would not be tolerated well. And a transcatheter valve, population is not tolerated well either. If you look at the partner to a valve-in-valve cohort, the nested registry, as well as the main body of the trial, that was the first time I saw a mortality difference. If you look at valve sizes, 26 versus a 23 millimeter Sapien XT, you had a mortality difference between those two, and that bore out in multiple regression. So, that was something that if you looked at a multivariate analysis, you were statistically significantly at higher risk of having an untimely death with a 23 millimeter valve versus a 26 millimeter valve. That's awful. And I think that was probably driven by the hemodynamics and really nothing else. And so if we look at Evolute platforms and core valve platforms, you can see that the dimensionless indices are reliably above 0.5. And so the hemodynamics across the supraannular platform are clearly well vetted. even in this paper, but then everything that's come since, we believe that the hemodynamics with the supraannular platform are better as they're conventionally assessed. Now, that kind of led to this really great analysis that was done by Mike Reardon and colleagues. I was a co-author on this paper. It just recently got published, basically looking at the 5-year incidence, outcomes, and predictors of structural valve deterioration, looking at the U.S. pivotal and TAVI trials. And so we had data on SAPIEN, and it wasn't good. It's not coincidence that the 5-year analysis from SAPIEN XT came out about a year and a half after SAPIEN 3 was launched commercially in the United States, because SAPIEN XT did not have great outcomes, and those curves definitely favored surgery by year 5, and no matter how you sliced it. So if that was the only TAVR valve, then obviously TAVR would be in trouble right now, but it's not. Clearly, SAPIEN 3 looked better out to 5 years, and then, of course, looking at the core valve evolute pooled analysis, we'll see how those sets of valves do in this particular study. And so there was this previous notion that 5 years of data, surgery would cross with transcatheter aortic valve replacement, and that really transcatheter aortic valve replacement may not be the most durable solution for your patient. But obviously there was a lot of observational data and prior analyses that showed lower rates of hemodynamic valve deterioration and reintervention due to stenosis with TAVR versus surgery, and reported an association between hemodynamic valve deterioration and clinical outcomes. So as we look further in this, we're just going to look at this 5-year incidence, outcomes, and predictors of structural valve deterioration in the US pivotal and TAVI trials. And so really we're talking about randomized controlled trials, as well as some continued access studies that were implemented within these studies. And then structural valve deterioration is basically per VARC 3 criteria, as shown here. Basically, if you have like severe degrees of aortic stenosis or aortic insufficiency affecting the TAVR valve. We did standard fine gray regression analyses, univariate Cox proportional hazard models, looking at association of structural valve deterioration with other clinical outcomes like mortality and worsening heart failure. So here were the demographics. It was largely an intermediate to high risk population, as would be inferred given the studies that we used. Standard age was around 81 years. STS predictor risk of mortality was up around 5%. The non-randomized controlled trial cohort was really a lot of US pivotal registries and continued access studies, and so that STS predictor risk of mortality was higher in that group. And you can see some of the other comorbidities listed there. So when we look at the pooled analysis for 5-year structural valve deterioration, adjusted for a competing risk of mortality, you can see here that out to 5 years, the supraannular platform did significantly better than surgery in the randomized control trial data. So significantly lower rate of structural valve deterioration with core valve and evolute versus surgery through 5 years. When we pick that apart a little bit more, the largest benefit appears to be in the smaller annular diameters and ranges. So looking here, this is what drove most of the statistical significance. Let me just fast forward there. You could see the effect size being greater there, and it was statistically significant, although barely it was. And you could see the difference, at least in effect size, between surgery and evolute there. If you look at larger valve sizes, there was a trend towards significance, and maybe when we do a 10-year analysis or whatever, we're going to see this, kind of get to significance, but definitely a trend in favor of core valve evolute versus surgery out to 5 years in these larger valve sizes. When we looked at rates of moderate and severe structural valve deterioration or degeneration, we saw obviously things favoring transcatheter aortic valve replacement in both of these major categories, most of it being stenosis versus regurgitation. When we looked at the pooled analysis and we looked at subgroups, and then we looked at other like finite outcomes, everything really favored TAVR at the end of the day. But then when you talk about really hard endpoints, This is really where structural valve deterioration, as per prior analyses, shows significance. All-cause mortality, cardiovascular mortality, rehospitalization rate, all goes up in a very significant way with a much higher hazard ratio if you have structural valve deterioration versus if you don't. So it's better to avoid that particular outcome clearly. You can see some of the characteristics here and some of the significant things that were different. Patients with structural valve deterioration tended to be younger, which was interesting, tended to have a lower STS score, which was interesting, and tended to have a lower incidence of prior atrial fibrillation and flutter. So it was almost like the clinical population that got structural valve deterioration was pointed away from getting it, but it was more really an essence of the valve that they were given that led to the structural valve deterioration, kind of it being not a device agnostic thing. It's more of a demographic agnostic thing, and that the device really takes over in determining who would get this particular potentially fatal outcome. So looking at the multivariate model here, you can see kind of what popped out in that: age, gender, body surface area, clearly some other things. But really, the whole thing here is the higher risk of developing structural valve deterioration in patients who have a higher body surface area and or who had surgery in these particular trials. So we're going to have 10-year follow-up in both TAVI, which was a protocol modification that happened around year 2 of follow-up. So all of those patients are being followed up to 10 years. The low-risk trial was per protocol out to 10 years, which is going to happen. And we're going to get more and more data about long-term impacts of structural valve deterioration as time goes on. In summary, you could see that, at least looking at the pooled analysis, there was a significantly higher rate of structural valve deterioration in the surgical arms of these pooled analysis trials. This difference was more profound in patients who had smaller diameter annuli, but you saw a trend even with the larger diameter annuli. Now, this definitely portended worse hard outcomes across the board. When you did have structural valve deterioration, you tended to have worse mortality, worse morbidity with regards to rehospitalization and worsening heart failure. And you can see some of the indicators that would have led to structural valve deterioration, but the highest one really being, or the biggest one really being higher body surface area. So this was really the only clinical trial analysis or pooled analysis to show lower rates of structural valve deterioration compared with surgery. In randomized control trials, there is the 8-year NOTION data as well that also shows less structural valve deterioration with the supraannular platform. A lot of this is going to be echo based, right? And so it all depends on whether or not you believe in echo data. And I would say that when we think about prognosis in our field, it has to harken back to echo. There's been nothing about invasive hemodynamics or hemodynamics that are calculated in another way that would support any kind of discrimination based on mortality, morbidity, heart failure rehospitalization like echo data does. And again, long-term follow-up is ongoing, but really durability should matter in your conversations, especially with your lower risk patients. But I would argue intermediate risk patients as well, people that you would see living 5 to 10 years, you really need to start thinking about durability and lifetime management in these patients. So when we think about the low-risk trials and where things are headed, we've got 3 years of analysis with the Evolut low risk. And with Partner 3, we just have the snapshot out to 2 years. Partner 3 started out with hemodynamics, echo-based hemodynamics that were worse than surgery. That's the first time that a clinical trial of TAVR versus SAVR started out of the gates worse hemodynamically. So lower mean gradient with surgery, statistically significantly lower mean gradient, whereas Evolut pretty much did what all of the things preceding this trial did, which shows superiority in hemodynamics across the board. Again, how this relates then to long-term durability, we're going to see once we get out to like 5 years, I think. And maybe these curves will cross. You saw the hard outcomes in partner 3 between year 1 and 2 be significantly different as far as what was different between surgery and transcatheter aortic valve replacement. I would expect that trend to continue, obviously out to 5 years. When we think about your low-risk patient and what trial actually does define your low-risk patient, keep in mind the screen fail rates of these respective studies as well. And so in partner 3, 1,520 patients were consented, but 520 were excluded from randomization. Whereas with Evolut low risk, you had a screen fail rate that was significantly different. And so 34% of patients in partner 3 were screen failed, predominantly because of anatomic reasons, whereas in Evolut low risk, only 15% were screen failed. A dramatic difference. And you could argue that Evolut low risk is probably a better indicator of what you have in your day-to-day population as far as commercial low risk is concerned. The SMART trial design, and it's serendipitous that I'm talking to you this evening. The last SMART trial patient was treated today. So that trial is now officially over, and hopefully we get 30-day outcomes that are presented to the public in the not too distant future, but the real primary endpoint is out to 12 months. So maybe they'll do some Bayesian analyses. I don't know. I've never seen any Bayesian analyses done with 30-day data that kind of relates it to 12 months. I've seen 12 months out to 2 years, but we'll see what they do statistically, and hopefully these data are available for us very soon. These were 700 patients that were randomized between the two platforms. So obviously the largest randomized controlled trial that was ever done between Evolut and SAPIEN 3. And we'll see what happens. And this included bicuspid trials. It was very much an all-comers style of trial. And one of the key primary endpoints was bioprosthetic valve dysfunction at 12 months, again, per VARC3 criteria. And so we'll have much more of an assessment with regards to the burden of bioprosthetic valve dysfunction across these two platforms in a year, if not less than that. So I think the majority of your SAPIEN 3 patients may be receiving a suboptimal outcome, because if you look at partner 3, a third of them got a 20 or a 23 millimeter valve. And so that's just not a good thing. You know, as I presented over and over again in the TVT registry analysis by Herman, the dimensionless indices that we saw in that paper by Hahn, and then of course the more recent analysis by Reardon, having smaller diameter annuli in intraannular fashion is generally not a good thing. And so in my patient population, a 23 millimeter SAPIEN 3 is looked at as the last potential choice in a low-risk patient. And obviously, if the surgeon can do a root enlargement and put in a larger surgical valve, we would prefer that over needing to put in a 23 millimeter SAPIEN 3. I would really start thinking hard about durability and how much of a mess potential limited durability out to just 5 or 7 years will create in a TAVR population that's being implanted right now. So all these 20 and 23 millimeter SAPIEN 3s that have gone in and continue to go in, I mean, I can only imagine what kind of mess we're going to be dealing with 5 to 7 years from now. The rest of the potential talk track here is about changing the color of the turf and telling you how bad of an interventional cardiologist that you are. So really all they want to do, all the other side wants to do, I would say, is kind of get you to think not about echo-based hemodynamics, but cath-based hemodynamics, which is completely off the radar. And then on top of that, they want to tell you that you can't re-engage coronaries. There will be no lifetime management, lifetime reaccess interventions that will happen between now and 5 to 10 years from now, which is myopic. Because if you think back 10 years ago and where technology was versus where it is now, it's dramatically different. So bottom line is, think about the data that we have currently, think about how durability will be impacted as a result of that data, and really do some critical thinking as to what valve is going to be the best for your individual patient. With that, I'm happy to answer any questions, and thanks for your attention this evening, and thank you again for involving me in this great symposium that you have.